Assalamu alaikum. My name is Dr. Almas, consultant dermatologist. Today, I welcome you all from the 10th CPC arranged by JPMC under the supervision of Dr. Rabia Ghafoor. Today's cases would not only teach you how to diagnose, manage, but would also teach you the importance of follow-up. So let's begin the session with our very first presenter, Dr. Parisa.
Assalamu alaikum. My name is Dr. Parisa Sanawar, and I am FCPS resident of Postgraduate Jinnah Postgraduate Medical Center, Karachi. Here I'm going to start my presentation. My patient is a 40-year-old female with no known comorbids. She is the resident of Kotri Thatta, Pakistan, and she came through OPD with presenting complaints of fever since 4 months, itchy papules on arms, legs, and trunk since 2 months, ulcer on the dorsum of her right foot since 1 month. There were nodular swellings over the left elbow and both legs since 15 days. According to my patient, she was in her usual state of health 4 months back when she developed fever, which was low grade, documented as 101 degree Fahrenheit, usually occurs in the evening, associated with night sweats, body ache, and joint pain. Not associated with any rigors or chills, sore throat, diarrhea, burning micturition, or cough. It was relieved by medicine. She noticed multiple papules 2 months back that first appeared symmetrically on both arms. Then it extended suddenly over a period of 1 week on both hand, forearm, trunk, and leg. The papules were itchy and associated with hemorrhagic discharge. The itching was moderate and occurs at any time of the day. There was no family history present of itching in the family. There was no erythema, burning sensation, or any prior history of blister formation before the lesions appeared. Lesions healed with hyperpigmentation. There were no aggravating or relieving factors present. After that, she noticed a nodular swelling that spontaneously appeared on the dorsum of the right foot 1 month back, which gradually increased in size over a period of 2 weeks and developed into an ulcer. This ulcer was associated with pain and purulent and hemorrhagic discharge. This pain was severe, gradual in onset, and aggravated on movements relieved by oral painkillers. The ulcer was persistent and didn't regress by taking any medicines. She also complained of similar nodular swelling since 15 days that extended over left elbow, left ankle, and both legs. There were purulent discharge along with severe pain in nodular swellings due to which her daily life activities were disturbed. The swellings were persistent and didn't regress by taking any medicines. There was history of weight loss positive, but that was undocumented. Malaise and body ache, night sweats were also present since 4 months. She noticed small lumps at the anterior side of her neck few days back. There was no history of Raynaud's phenomena, photosensitivity, oral ulcers, morning stiffness, proximal myopathy, and red eye. There were no history of previous scar formation or recurrent similar lesion. No history of lesions occurring at the site of trauma. Systemic inquiry. Systemic inquiry was performed. There were right shoulder joint pain and right knee joint pain positive. Weight loss was mentioned earlier. Personal history was appetite decreased and sleep was decreased. Past history was insignificant. Gynae and obstetrical history showed the age of menarche was 12 years. There were normal regular cycles. She had 8 children in total. All were spontaneous vaginal delivery. There was one history of miscarriage at 3 months of her pregnancy. Drug history showed she took multiple oral and intravenous painkillers that included tablet diclofenac 50 mg BD for body aches and joint pain. There was no history of prior vaccination or any other drugs taken. There was no history of any Hakimi medicines taken. Socioeconomic history was satisfactory. Family history was insignificant. On examination, she was a middle-aged female with average height, normal build, sitting uncomfortably on bed. She was well-oriented to time, place, and person. She looked anxious due to the pain in her right shoulder joint and right knee joint. Vitals were normal. She was stellar, and there was lymph nodes positive. Anterior cervical was greater than 1 centimeter, and inguinal lymph nodes were greater than 1.5 centimeter. They were fake sperm and non-tender. Cutaneous examination. Cutaneous examination showed there were multiple dome-shaped papules prominent over the bilateral extremities and trunk. It spared face, head and neck, abdomen, buttocks, and palms and sole. They were of various sizes and color. Few were erythematous and few were necrotic papules present on the dorsum and volar speck of her hands. There were few plaques also appreciated. The plaques had central scaling and erythematous base. The plaques were firm, non-tender, and surrounding skin was normal. Here we can appreciate few plaques on the dorsum of her right hand, and there are necrotic papules at her back. There was one single ovoid large ulcer on the right foot measuring about 6 to 7 centimeters in diameter. It had central hemorrhagic cracks with indurated borders and surrounding hyperpigmentation. This ulcer was firm, tender, but non-adherent. Temperature gradient was positive. Peripheral pulses and sensations were normal. The most important part of the examination showed there were 4 well-demarcated nodular swellings. One on left ankle, second on left elbow, third and fourth on both legs. These were well-defined nodules with surrounding erythema. The nodules were soft, tender, but not adherent. Purulent discharge was present on squeezing these nodules. Peripheral pulses and sensations were normal. Temperature gradient was positive. On further examination, there was an incidental finding in this patient. There was an indurated ulcer on the left side of the tongue of this patient. It was measuring about 1.5 to 2.5 centimeter in diameter. This ulcer was resolved in 1 week. On cardiovascular examination, it was normal. Abdominal examination showed spleen was palpable 1.5 centimeter below the costal margin. On respiratory and CNS examination, it was normal. But right upper limb and lower limb power could not be assessed due to pain. Musculoskeletal examination showed there are right-sided movements restricted due to shoulder joint pain and right knee joint pain. Differential. My differentials on the basis of history and clinical examination showed that Sweet syndrome, pyoderma gangrenosum, leukemia cutis, lymphomatoid papulosis, pityriasis lichenides at varioliformis acuta, and papulonecrotic TB. Investigations were done in this patient. Complete blood count, peripheral film shows anisocytosis, poikilocytosis, leukopenia, atypical mononuclear cells with occasional blast cells present. Her further CPC report shows pancytopenia. LDH was raised, CRP was raised, CPK and uric acid were also raised. Her skin biopsy was performed. There were 2 specimens taken. One specimen was taken from tender nodule, and the second specimen was taken from a necrotic papule. Her skin biopsy shows inflammation composed of lymphocytes, plasma cells, neutrophils, and fibrin. Here is the histopathological report present. That shows that features are consistent with neutrophilic dermatosis. There was no evidence of malignancy seen. Here we can see there are hyperkeratosis is appreciated in this picture with mixed infiltrate in the dermis and around adnexa. Bone marrow terpene biopsy was performed. There was diffuse infiltration of blast cells that constitute 50% of non-erythroid cell population. Variable nuclear to cytoplasmic ratio was present. Case summary. According to my patient, on history, we found out that there were fever, night sweats, body ache, and joint pain. On examination, we found out there are tender cystic nodules with necrotic papules and ulcers. Peripheral smear showed atypical mononuclear cells and occasional blast cells. There was mild splenomegaly on examination of abdomen. Skin biopsy shows features of neutrophilic dermatosis. Bone marrow aspirate shows diffuse infiltration of blast cells. Final diagnosis. Our final diagnosis was made as atypical Sweet syndrome secondary to hematological malignancy. Treatment was given in the ward and further plan was discussed. Oncologist was taken on board. The oncology department referred and advised her for bone marrow biopsy with cytogenetics and immunophenotyping. She was discharged on 30th April 2022 and referred to follow-up oncology. At the time of discharge, her lesions were improved. The patient lost to follow-up and then went for cytogenetics and immunophenotyping test advised by oncologist. Actually, her attendance refused for the test. According to her attendance, she then died on 18 July 2022 due to some chest infection. Topic discussion. Neutrophilic dermatosis Sweet syndrome. Actually, neutrophilic dermatoses are autoinflammatory skin conditions characterized by dense infiltration of inflammatory cells, mainly composed of neutrophils in the affected tissue. Here we are concerned with Sweet syndrome, one of the type of neutrophilic dermatosis. Sweet syndrome is characterized by tender erythematous plaques. These are its typical presentation that are most commonly present on arms, upper body, head, and neck. It is associated with fever and peripheral leukocytosis, most common in women. The diagnostic criteria. The diagnostic criteria of Sweet syndrome includes both of the major criteria and 2 of any minor criteria for malignancy associated as well as for classical sweet syndrome. Atypical presentations of sweet syndrome are nodular, pustular, vesicular, bullous, targetoid, oral, and genital lesion, pyodermal gangrenosum-like and erythema nodosum-like. Malignancies are associated with sweet syndrome, few are hematological and few are solid. The most common ones are acute myeloid leukemia, promyelocytic leukemia, and chronic myelogenous leukemia. Literature review was done in my patient. There were few cases reported that show there is a strong association with atypical cases of sweet syndrome and myelodysplastic syndrome and acute myeloid leukemia. This was present in British Journal of Hematology. There was another case report seen in the Journal of Nippon Medical School that says that a case of sweet syndrome had extensive necrosis and ulcers. These are the atypical presentations of sweet syndrome, and it was accompanied by myelodysplastic syndrome. There was a 43-year-old woman that presented with persistent fever and these extensive necrosis and ulcers, as we can see in this picture. The third case report was seen that also says that acute myeloid leukemia has the strongest association with sweet syndrome, accounting for approximately 42% of associated hematological malignancies. Thank you. Now I call upon Dr. Nazia Dabeen for a further case.
Assalamu alaikum. My name is Dr. Nazia Javeen and I am FCPS resident of Dermatology Department at Jinnah Postgraduate Medical Center. Today I will present a case of my patient. My patient was a 6-year-old male resident of Umarkot, madrasa student, presented to us through ER with a known comobs, presented with a complaint of swelling of right hand associated with fever since 25 days, painful deep nodules over abdomen, trunk, neck, and face since 10 days. On his history of presenting complaint, according to patient's father, he was all right 25 days back when he suddenly developed swelling of right thumb that gradually increased and became generalized, started from tip of fingers and extended up to the wrist joint, associated with pain and fever. There was no history of discharge. Pain was severe that he was unable to move his fingers and wrist joint. Relieved temporarily after taking the painkillers. His fever was high-grade, intermittent, and relieved with antipyretics. There was no history of any rigors, chills, sore throat, burning micturition, and diarrhea. After a few days, he developed multiple painful nodules, which first appeared on abdomen, then noticed on the neck, chest, back, and bilateral cheeks over a period of 1 week. There was no change in size noticed by the parents. Nodules were associated with mild itching and moderate pain. Initially, the overlying skin of nodule was red, then it gradually changed its color within few days. There was no associated ulceration, discharge, and burning sensation. The patient also had difficulty in walking and weakness of both legs and arms, which according to his father, it was gradual in onset, affecting his daily activities of life. His father also gave history of face burning with sun exposure, but never noticed any malar rash. There was no history of oral ulcer, morning joint stiffness, hair loss, weight loss, change in color of fingers with extreme of cold, taut skin, digital ulceration, dysphagia, discoloration on body or around the eyes, dry mouth, dry eyes. There was no history of prior vaccination, any Hakimi medication use, trauma, and insect bite. He visited his nearby hospital where he was treated with IV injectables, medication, but his condition did not improve. So he was referred to Karachi and admitted at NICH hospital where he was treated as a case of cellulitis. Then they advised dermatological opinion for which he was referred to us. His father also told that during his stay at NICH, he developed red non-itchy scattered spots over both his legs that extended up to the hip region, which subsided within 3 to 4 days. With a post-inflammatory hyperpigmentation, they were not associated with bleeding and ulceration. On systemic review, it was concluded that patient had a right hand pain and swelling and proximal muscle weakness. The rest of the systemic review was unremarkable. On personal history, his appetite was decreased and sleep was disturbed due to the pain. And his past medical and surgical history was unremarkable. He was fully vaccinated and his milestones were achieved on time. On drug history, he usually used to take Panadol for his symptoms, SOS. There was no history of allergy. Family history was insignificant. Socioeconomic history was satisfactory. On examination, there was an anxious-looking, irritable boy who was well-oriented, non-cooperative throughout the examination. His blood pressure, pulse, respiratory rates were normal, but he had a fever of high grade 103 degree Fahrenheit. On subvitals, he was pale, and bilateral submandibular lymph nodes were palpable. They were of around 1 centimeter in size, tender, firm, and mobile. On cutaneous examination, start from his hand examination. Here you can appreciate the generalized right hand swelling with erythematous scaly plaques more prominent over the palms. There is a mild dryness and hyperpigmentation present over the fingers. On palpation, his hand was warm and tender. Pulses were intact. Here we can appreciate the ragged cuticles and the capillary dilatation of the nail folds. There were multiple skin-colored, deep-seated subcutaneous nodules present over the abdomen, trunk, back, and neck, sparing scalp, buttocks, and bilateral extremities. These nodules were firm, tender, non-adherent, with positive temperature gradient. And they were of various sizes, the largest one measuring about 4 to 5 centimeters in size, which was present on the left flank region. Is the similar morphology nodule present over the neck. This is another similar morphology nodule, which was present over his face, with overlying skin is erythematous and violaceous, with central crust and surrounding hyperpigmentation. Here you can see the post-inflammatory hypopigmented patch over the upper chest. Findings on the scalp, hair, mucosas were insignificant. There were also multiple purpuric macules present over bilateral lower extremities. They were non-tender, non-blanchable with normal temperature. There was no discharge associated, and pulses were intact. So on musculoskeletal examination, the patient was unable to work himself. He was taking his father's support, and his Gower sign was positive. And the power in all the 4 limbs were decreased up to the grade 4. His abdominal examination, chest examination, cardiovascular were all unremarkable. And over the CNS examination, apart from the powers, rest of the CNS examination was unremarkable. So now come to the case summary. On the history, there was a right hand swelling associated with fever, multiple nodules over the face, neck, trunk, and abdomen, positive photosensitivity, and proximal muscle weakness. On examination, multiple tender deep-seated subcutaneous nodules present over the abdomen, trunk, neck, face. Gower sign was positive, ragged cuticles and capillary dilatation of nail fold were present, and powers were decreased on all 4 limbs. So on the basis of our history and clinical examination, we decided our differentials on the following differentials were decided. Lupus, it includes the lupus panniculitis, juvenile dermatomyositis with lupus panniculitis, overlap, infective panniculitis, and fictitious panniculitis. So his lab investigations were done. On CBC, it showed low HB with low MCV, and his TLC count was slightly raised. His peripheral film showed the hypochromic microcytic anemia, and his LFTs, renal profile, coagulation profile, and urine ER were all normal. His CRP, ESR, and LDH levels were raised, and RF factor and viral serology and blood cultures were negative. ANA profile was done, which ANA came out to be positive, and his lupus anticoagulant was weak positive. ENA profile was done, which showed the SCL70 positive, and rest of the antibodies were negative. His complement levels were done. C3 levels were at the lower limit, and direct Coombs test was positive. And muscles enzymes were done. CPK levels and serum aldolase were in higher ranges. So his ANA panel by immunoblot was done, which showed the anti-MI2 antibodies and anti-KU positive. And his radiological evaluation was done. It was unremarkable. His chest X-ray, his ultrasound Doppler of arm, right hand X-ray, abdomen were all normal. And his EMG and muscle biopsy was planned, but that was refused by the parents. This is the chest X-ray, the other hand X-ray. His ULR criteria was calculated, which the total score was 12, and SLEDAI score was calculated as 7. So we planned for his skin biopsy, and his skin biopsy was done, and it was showing the lymphocytic infiltrate in the lower dermis and adipose tissue. And these findings were consistent with the lupus panniculitis. Here we can appreciate the fat lobule with lymphocytic infiltrates. This is the magnified view of the previous slide, which showed the lymphocytic infiltrates surrounding the fat globules. And his fundoscopic examination was also done, which was normal. So on the basis of our investigations, our final diagnosis was made, which was of juvenile dermatomyositis with lupus panniculitis overlap. So we treated the patient, and he was given the treatment of prednisolone, methotrexate, and hydroxychloroquine. And as you can see, the patient improved and responded very well to the treatment. And after 6 weeks, all the lesions were resolved, and he was able to walk by himself. So now come to the literature review related to the panniculitis and dermatomyositis. So there were very few cases reported related to our topic. So this is a case of a 16-year-old female presented with lupus panniculitis as the presenting skin feature of juvenile dermatomyositis, and it was published in 2022. This is another case report of a 10-year-old female who presented with coexisting panniculitis and juvenile dermatomyositis, and it was published in 2017. And this is the another case report. In this panniculitis in a patient of a 30-year-old female was with dermatomyositis was reported, and this was published in 2009 in Argentina. Thank you. Now I would like Dr. Mariam to come and present her case.
Assalamu alaikum. My name is Dr. Mariam. I'm an MCPS resident in the Department of Dermatology, and I'll be presenting a case which was from January 2022 about a 40-year-old female married housewife, resident of Balochistan with no known comorbids, who was admitted by an ER with a presenting complaint of generalized redness and scaling all over the body since 1 week. History of presenting complaint. According to my patient, she was all right 15 months back when she noticed a flat hypopigmented lesion over the right forearm, which gradually increased in size and over 2 to 3 weeks extended from the wrist to the mid-forearm. It was associated with mild itching, numbness and tingling, decreased sweating, and hair loss over the lesion, along with dryness of skin, but no associated scaling or pain was present. Over a period of a few weeks, similar hypopigmented lesions appeared over the arms, back, buttocks, sparing the chest, abdomen, face, legs, genitals, axilla, and hands and feet. Around the same time, there was history of loss of 2 lower frontal teeth without prior history of trauma. She also noticed numbness and tingling over the hands and feet. Upon cooking, she was unable to appreciate the heat from the stove, and her slippers would slip off her feet while walking. There was no functional impairment, but she was unable to appreciate pain upon trauma, which led to necrosis over the fingers, and surgical amputation was done by local doctors. After which she was referred to the leprosy center, where she was diagnosed as a case of leprosy and her treatment was started. The hypopigmented lesions persisted, but were static, without any development of any new erythema or lesions. There was no history of any pain or redness in the eyes, changes in vision, smell, taste, hearing, epistaxis, nasal or oral ulcers, difficulty in chewing or swallowing, changes in voice or nails, thickening of skin, deepening of creases, loss of eyebrows, eyelashes, changes in hair, swelling of legs. In January of 2022, she had been on treatment of leprosy since 10 months when she went to a nearby clinic for treatment of recurrent fever with rigors and chills, which were sudden in onset, intermittent, aggravated at night, and temporarily relieved with oral medication. The next day, she developed asymptomatic redness over the chest, which became generalized within 2 days, followed by gradual appearance of scaling all over the body. The fever subsided in 4 to 5 days, but the erythema and scaling persisted. She was admitted at the leprosy center where her treatment was continued, and she was referred to JPMC for evaluation of erythroderma. On cutaneous examination, as you can see, there's generalized erythema present along with grayish-brown scales all over the body. Similar pattern of scaling and erythema can be seen over the trunk. Multiple discrete hypopigmented patches were present over the sides of the trunk, buttocks, and arms, distributed symmetrically over the arms and asymmetrically over the trunk. The largest patch was present on the right side of the trunk, about 12 by 7 centimeter in size, with well-demarcated regular margins. The overlying and surrounding skin appeared rough, with brown ichthyotic scales that were firmly adherent, and the sensation was intact over the lesion. There was loss of sensation in glove and stocking distribution up to the mid-forearm and ankles, along with loss of temperature, pain, touch, vibratory sensation, along with weakness in the limbs. Bilateral ulnar, bilateral radial cutaneous, and the left common peroneal nerves were thickened, palpable, and non-tender. As you can see in this picture as well, multiple areas of necrosis can be seen, and ulceration over the left thumb and the right forefinger can also be appreciated. A provisional diagnosis of drug-induced exfoliative dermatitis was made and cutaneous biopsy was done. Additionally, she was advised topical and oral corticosteroid that led to improvement, and she was discharged from the leprosy center in February 2022. A few weeks later, in March 2022, she went into flare with worsening of her condition. And she came to us presenting with the complaint of fever on and off since 21 days and generalized erythema and scaling since 20 days. According to her, she had developed a similar episode of high-grade fever for which she went to a local clinic and was given an undocumented IV medication. 1 day later, she developed generalized asymptomatic redness starting from the trunk and extending to the whole body in over a period of 2 days, along with grayish-brown scaling, which was shed spontaneously without bleeding and was about half a fistful every day. And over a period of 10 days, her skin became progressively darkened. Additionally, she noticed dry scalp hair with loss of hair from the rest of the body. She developed nail changes and yellow discoloration of the nails, but there was no any thickening or shedding of the nails. There was redness and gritty sensation in the eyes. There was history of weight loss since 2 months, along with swelling of the feet since 20 days. There was no gastrointestinal, urinary, respiratory, or musculoskeletal complaints, and there was no orange pink discoloration of the bodily fluids or lumps or bumps. The systemic review has been discussed. In the past medical history, she was admitted at the Leprosy Center, Karachi in January 2022, and there's no prior history of any viral infections, TB contact. The past surgical history was unremarkable. The gynecological and obstetric history was also unremarkable. Now, the drug history is important in this patient. She was on multivascular regimen for 1 year, which was stopped 1 month back. Topical and oral corticosteroids were taken by her for a few weeks in January 2022. An undocumented IV medication was given 1 day prior to development of erythroderma, and there's no prior history of any homeopathic medication. The vaccination and transfusion history is unremarkable. In the personal history, sleep and appetite were decreased, and the weight loss history has already been mentioned. In the allergic history, she gave history of seasonal runny nose, but there was no history of any weeping skin, difficulty in breathing, allergy to food, glass, pottery, ceramics, petrochemicals, clothing material, or sunlight. Now, the family history is also of significance in this patient. Her husband had history of leprosy 8 years back, for which he underwent treatment. There's no any other illness in the family. The socioeconomic history was unsatisfactory. Examination at the time of readmission in March 2022, I had a middle-aged female of average height and lean build, well-oriented, lying uncomfortably on the bed, complying with commands with temperature of 101 degrees Fahrenheit, and the rest of the vitals were normal. In the subvitals, pallor and dehydration was positive, and pitting edema was present up to the bilateral knees. GVP was raised, and on lymph node examination, bilateral cervical lymph nodes were palpable, 3 on the right anterior cervical chain, 2 on the left, with the largest on the right side, 0.5 by 0.5 centimeter in size, mobile, rubbery, and non-tender. Bilateral inguinal lymph nodes were palpable, 3 on the right side and 4 on the left, with the largest being on the left side, 1.5 by 1 centimeter in size, mobile, rubbery, and non-tender. A single right axillary lymph node was also palpable, 0.5 by 0.5 centimeter in size, mobile, rubbery, and non-tender. The rest of the lymph nodes were not palpable. On cutaneous examination, there was generalized dryness and hyperpigmentation with some hypopigmentation, with loose to moderately adherent gray ichthyotic scales present all over the body. On cutaneous examination of the face, the skin appeared dry, shiny, and taut, with the whole face covered with grayish-brown, dirty scales that were moderately adherent and removed to reveal a hyperemic base. Few bleeding points and hemorrhagic crusting, as you can also see in this picture, can be appreciated over the left side of the mouth, both the cheeks, glabella, and forehead. Bilateral ectropion, along with loss of eyebrows and eyelashes, was also present. Her lips appeared thin, with hyperpigmentation of the upper lip, but the mouth opening was normal. There was no thickening of the earlobes, and on examination of the scalp, there was mild scaling, and the hair appeared gray to black, dry, brittle, and lusterless. As you can see, similar pattern of scaling can be seen over the arms and legs. On examination of the hands and feet, there appears to be dry scale on palms and soles, yellowish keratoderma over both the soles, hyperpigmented macules and patches were present over the soles with ill-defined irregular margins. Hyperpigmentation of skin interspersed with linear streaks of hypopigmentation were present on the dorsal surface of hands and feet. As you can see in this picture as well, the right forefinger is amputated up to the distal differential joint with loss of tip of left thumb. It is covered with brown scale. On examination of the nails, there was yellowish discoloration of the nails with rough textured nails and longitudinal ridging and loss of cuticle. On mucosal examination, the conjunctiva appeared red with nasal crusting present. On oral cavity examination, there was loss of lower two incisor teeth with yellowish discoloration of the teeth. No oral ulcers or blisters were present and the genital mucosa was normal. Systemic examination. We start with the CNS examination. The higher motor function, cranial nerves, speech, and cerebellar functions were intact. Now, examination of the peripheral nerves. As in the first presentation, bilateral ulnar nerve, bilateral radial cutaneous nerve, and the left common peroneal nerve were palpable, thickened, and non-tender. There was sensory loss in glove and stocking distribution up to the mid forearm and ankle, with loss of temperature, pain, touch, vibratory sensation. On examination of the motor system, bulk was decreased in all the limbs with power of grade 4 in all the limbs. The tone and the reflexes were intact. Now, disability due to leprosy was graded to be of grade 2 over the hands, grade 1 over the feet, and grade 0 over the eyes. The respiratory and CVS examination was normal. Now, the GI examination is of importance in this patient. Her abdomen was sunken, soft, and doughy. The liver was palpable, 3 centimeters below the costal margin, with the liver span being 18 centimeters, and it was non-tender. The spleen was palpable, 5 centimeters below the costal margin, with the span being 17 centimeters, and it was also non-tender. The renal punch was negative with no signs of free fluid, and the gut sounds were audible. Now we start with the case summary. 40-year-old female, treated case of leprosy, presented with history of fever and erythroderma associated with weight loss. On examination, there was generalized hyperpigmentation with some hypopigmentation with loose ichthyotic scales with cervical, inguinal, and axillary lymphadenopathy, hepatosplenomegaly, bilateral ulnar, radial cutaneous, and the left common peroneal nerve thickened, palpable, and non-tender, and glove and stocking type anesthesia was present. Now, based on our history and examination, our differentials were drug-induced exfoliative dermatitis, rare presentation of erythroderma as a case of reversal reaction, erythrodermic mycosis fungoides, and cutaneous sarcoidosis. Now, investigations. Cutaneous biopsy was performed from 2 sites, one from the hypopigmented lesion over the arm and one from site of erythroderma over the back. The histopathology showed patchy parakeratosis, variable acanthosis, focal spongiosis, and prominent basal vacuolar change. Scattered lymphocytes in the lower layer of the epidermis with large convoluted nuclei reaching the upper layer as well. Papillary layer shows fibrosis, lichenoid infiltrate at dermoepidermal junction comprising of lymphocytes, histiocytes, and melanophages. Granuloma formation was absent and PAS and AB stains were negative. Now, as you can see in these histological sites, epidermotropism can be observed along with large convoluted nuclei of the cells. Immunochemical stains were positive for CD3. CD4 was positive in the dermal lymphocytes. CD8 was positive in epidermotropic and dermal lymphocytes. Now, these features favor hypopigmented mycosis fungoides in both the specimens. Some routine hematological investigations were performed, which showed normocytic anemia, and no atypical lymphocytes were seen on peripheral smear. Some biochemical analyses were done, which showed creatinine levels to be raised. ALP was also raised, and the serum albumin and total protein were in the lower ratio. The coagulation profile, urine DR, LDH, ESR, and CRP were normal. The direct Coombs test was positive. The viral serology for Hep B, C, and HIV was negative. In the thyroid profile, the TSH was in the normal range and the T3 and T4 were reduced. In the nutritional profile, TIBC, serum ferritin, and B12 were raised and vitamin D3 within the lower range. Some radiological investigations were also done, of which the chest X-ray was normal. The ultrasound abdomen showed splenomegaly. Echocardiogram and ECG was also normal. Ultrasound neck showed impression of diffuse thyroid disease, bilateral few subcentimeter cervical benign looking lymph nodes, for which we got an endocrine review done and thyroid scan was advised, which was normal. CT cap showed hepatosplenomegaly, mild abdominopelvic ascites, and multiple enlarged bilateral inguinal lymph nodes. PET scan was done, which showed hepatosplenomegaly, mild abdominopelvic ascites, mild to moderate FDG avid enlarged lymph nodes in the cervical, axillary, abdominopelvic, and inguinal region. But there was no hypermetabolic involvement. The lymph node FNAC did not show any malignant cells. So our final diagnosis of mycosis fungoides stage 3A was made, with a 5-year overall survival of 41 to 57%. So our treatment involved a multidisciplinary approach involving the dermatology department, oncology, general surgery, endocrinology, and ophthalmology. The specific treatment that was given in our ward included topical corticosteroids and topical emollients. Systemic therapy with lenalidomide monotherapy, which is an immunomodulatory drug, was started after consultation with oncology, and I will speak about it later on. Multiple PCV transfusions were done, and symptomatic treatment was given in the ward. Our patient was discharged in April 2022, and as you can see, she is quite improved. Some scaling had persisted, for which we advised emollients, and few areas of hypopigmented macules and patches were present over the back, arms, legs, and hands and feet. So our patient was unable to come to us for follow-up due to affordability issues, and she sent her pictures to us recently from her village. And as you can see, she is quite improved. Topic discussion. So what is lenalidomide? Lenalidomide is an immunomodulatory drug that upregulates the Th1 microenvironment. It has been shown to be effective in advanced refractory cutaneous T-cell lymphoma. It is an orally administered drug and is characterized by an acceptable safety profile, and clinically relevant interactions with other drugs are unlikely. It shows its anti-proliferative effect by G1 cell cycle arrest and causing apoptosis of the neoplastic cells. It demonstrates its anti-angiogenic effect by reduced VEGF production. And it brings about its immunomodulatory effect by increased NK T-cell response, CD8 positive T-cell activation, and interleukin-2 mediated T-cell stimulation. Its adverse effects include fever, rash, GI upset, flu-like symptoms, arthralgia, myalgia, UTI, dizziness, thrombocytopenia, and neutropenia. So in 2014, results of an open-label, multi-center phase 2 trial of lenalidomide monotherapy in refractory mycosis fungoides and Sézary syndrome was published using the data of 32 patients. This trial showed that an overall response rate of 28% was present with this treatment and a median overall survival of 43 months. Data from correlative studies suggest that the effect of lenalidomide could be associated with decreased circulating CD25 and CD4 T cells. The skin lesions also showed a decreased CD4 and CD8 ratio, which in conclusion demonstrates lenalidomide to be effective in refractory cutaneous T-cell lymphoma. Now, there's a paucity of data available regarding a coexistence of mycosis fungoides with leprosy. One case was found, published in 1994, where a patient with mycosis fungoides developed leprosy. This raises the question of a possible association between mycosis fungoides and leprosy, but there's a lack of data available, and we plan to report the case of our own patient. Thank you. Now I would like to advise our supervisor, Dr. Rabia Ghafoor, to come.
Good morning, everyone. Thank you very much for joining us in the 10th Clinicopathological Conference, which is going on monthly for last 1 year, and it is our second conference. In today's CPC, we presented 3 cases. First case was a patient, a middle-aged lady with like lesions, and this patient had hematological malignancy, which was not, we could not define it, as further cytogenetic studies were not done. It was either AML or ALL, and she was diagnosed as having the Sweet syndrome, atypical Sweet syndrome, secondary to hematological malignancy, and she responded to corticosteroids and antibiotics, but unfortunately, patient succumbed to chest infection. Second case presented by Dr. Nazia Jabin, which was of tender subcutaneous nodules in a boy of 6 years, along with proximal myopathy and ragged cuticles uh, and vasculitic lesions. And this patient was diagnosed as lupus panniculitis overlapping with juvenile dermatomyositis, which is also a very rare case. And this patient also responded well with the treatment of methotrexate, prednisolone, and hydroxychloroquine. Third patient is a very unique patient. It was a patient of leprosy and her with glove and stocking sensation loss, loss of finger, loss of sensations, and hypopigmented lesions, and who developed erythroderma after 10 months of anti-leprosy treatment. We initially diagnosed, kept the impression of drug-induced erythroderma, but the patient's erythroderma progressed and she got very critical. We already had done 2 biopsies, and both of these 2 biopsies showed the cutaneous T-cell lymphoma, mycosis fungoides in the stage 3A. And we used in consultation with oncologists, we use a novel agent lenalidomide for her treatment, and you can see the excellent response of the patient's skin after 1 year of treatment. In this case, there are 2 points. That one is we should in leprosy, although it is we diagnose it on the cardinal signs, and patient's husband was also had treated case of leprosy, and she had all the typical lesions and sensory loss and palpable nerves of leprosy. But the skin biopsy was not done initially before starting anti-leprosy treatment. And secondly, there are new treatment options for cutaneous T-cell lymphoma, and we can see the excellent response. I hope, I thank you everyone who joined. And we have Dr. Shiraz Dawaj with us, who is General Secretary PAD. I like him to give some comments. Sir, Dr. Ijaz, Professor Ijaz, please.
हाँ जी जी जी,
please
thank you
welcome
very
for your
much.
comment.
डॉक्टर राबिया, अच्छा मैंने सारे केसेस माशाल्लाह सुने, दे वर वेल प्रिपेयर्ड. उनका प्रॉपर जो सारा डायग्नोस्टिक होमवर्क हुआ था, प्रॉपर हिस्ट्री, क्लिनिकल एग्जामिनेशन, प्रॉपर इन्वेस्टिगेशन, हिस्टोपैथोलॉजी, और जो ये सारे केसेस का, और जो आखिरी केस हमने वो लेप्रेसी और वो सुना था क्यूटेनियस टी सेल लिम्फोमा के साथ एरिथ्रोडर्मा जो था, तो उसका फॉलो अप भी था. दिस वाज वेरी गुड कि आपने फॉलो अप किया, वो विजिबल इंप्रूवमेंट वाज देयर. तो माशाल्लाह, यू डिजर्व एंड योर टीम डिजर्व्स वेरी गुड अप्लॉज के आपने सारा अच्छे सीपीसी प्रेजेंट की, और सारे होमवर्क के साथ, सारी इन्वेस्टिगेशंस के साथ, कि आप उसका डिफरेंशियल वाज एक्सेलेंट. उनकी जो डिस्कशन थी, जो आपने उसके रेफरेंसेस शेयर किए, न्यू ड्रग ट्रीटमेंट ऑफ क्यूटेनियस टी सेल लिम्फोमा, तो दिस वाज वंडरफुल एक्टिविटी. आई माई सेल्फ लर्नड अ लॉट, और मैं आपसे रिक्वेस्ट करूंगा कि ऐसी एक्टिविटीज फ्यूचर में भी कंटिन्यू रखें. और अगर डॉक्टर सादियाज जो है आगा खान में अगर आप लोग भी करते हैं, तो आई वुड लाइक कि उसको भी मैं ज्वाइन किया करूं. डॉक्टर राबिया, आई वुड रिक्वेस्ट कि आप पहले बता दिया करें, सो दैट कि आपकी ये एक्टिविटी ज्वाइन की जा सके. दिस इज वंडरफुल एकेडमिक एक्टिविटी. Congratulations to you and all of your team. Thank you very much.
Thank you, sir. Your comments means a lot. This is 10th CPC. We are doing it for last 10 months. Inshallah, we will share it on the national forums as well.
Assalamu alaikum, Rabia. Can you hear me?
Yes, Dr. Najia.
Okay. Yeah, I'm Dr. Najia. It was an excellent case presentation. Congratulations, Rabia, and the whole team JPMC. I would just like to make a small comment about the last case. It's an excellent case, very informative, very well presented. But I would just like to highlight one thing. Maybe I missed, or maybe it was actually that lenalidomide is related to thalidomide actually, and it has well-known teratogenicity. So this aspect was missed, I think, during the presentation. And since she was a young patient, it wasn't told that she was counseled about teratogenicity and stuff. So giving lenalidomide, we must keep in mind the known teratogenetic effect. Thank you very
Yes.
much.
Thank you very much, Dr. Nadia, for highlighting a very important point. This patient had completed this family and was middle-aged women. She already had 8 kids, but this point should definitely be kept in mind in future for any case, if you want to treat any case.
Assalamualaikum. Can you hear me, Dr. Rabia?
Hey, Dr. Humaira, we can hear you.
Assalamualaikum, everyone. Very well presented and very detailed, especially the last one. I must congratulate you and your team for the hard work behind. And I would like to ask whether about the third case, whether both the symptoms of the 4 diseases started together, or did she develop erythroderma and scaling after 10 months?
She was diagnosed as leprosy in a peripheral center in Balochistan near her hometown. At that time, she had hypopigmented lesions on the skin. She had glove and stocking sensory loss, palpable nerves, and amputation of one finger after neuropathic ulcer. And she had neuropathy. But she developed erythroderma after 10 months. That is why we kept drug-induced erythroderma and rare and reversal reaction, which erythroderma may be a reversal reaction of leprosy, but this patient turned out to be cutaneous T-cell lymphoma after, and we did 2 biopsies to confirm that. And that is why I said that the initial biopsy was not done, but she had all the clinical symptoms of leprosy, and her husband was also a treated case of leprosy.
Okay, this was a good case because patient presented with 2 varied dermatological presentations. Thank you, Dr. Rabia.
Thank you.
Dr. Rabia, can you hear me? I'm Dr. Sadia Tabassum.
Yes.
Excellent cases and very well presented. Congratulations to your team and looking forward for more such programs. And जैसे Professor Ejad ने कहा, तो we are doing turn by turn. So inshallah सबकी बारी आएगी इसमें. So ये उनको मैं respond कर रही हूँ. वैसे it was a great session.
Thank you, Dr. Sadia.
अस्सलाम वालेकुम, मैं डॉक्टर शिराज बात कर रहा हूँ, जनरल सेक्रेटरी। मैं कांग्रेचुलेशन कर रहा हूँ डॉक्टर राबिया गफूर का, एक्सीलेंट। थोड़ा सा सॉरी करूंगा तो लेट हो गया क्योंकि मैं ओपीडी में इधर बिजी था गवर्नमेंट हॉस्पिटल में। तो मैंने लास्ट केसेस देखे तो बेहतरीन जबरदस्त होकर हम हमारा रिफ्रेश कर दिया माइंड। वंस अगेन कांग्रेचुलेशन डॉक्टर राबिया गफूर, और कीप इट अप। और मैं तो कह रहा हूँ जो भी करे सीरीज, तो हम ये जूम के साथ जो है ना, जो हम इंटीरियर स्किन में बैठे हुए हैं, जो बिल्कुल ही डर्मा के चीज़ों से अलग बैठे हुए हैं, तो थोड़ा सा हमें भी हमारे नॉलेज को इजाफा हो जाएगा। थैंक यू सो मच।
Thank you, Dr. Shiraz, for your kind comments. Thank you, everyone, for being with us for last 1.5 hours. I hope it was a great learning experience for all, and we are looking forward for the next month's CPC. Thank you very much.